invite Dr. Gavin Tan next to talk on something very interesting and something futuristic, home monitoring to manage AMD, something that's going to be very relevant in times to come. Dr. Gavin.
On this topic. So these are my financial disclosures. So we know in age-related macular degeneration, we have a very successful treatment, and that has really revolutionized the way or the outcomes we get with exudative age-related macular degeneration. We know there are various treatment strategies where we keep trying to push the limit of how long we can extend treatment because patients do not want to come back for monthly injections. And we know there's now an increasing number of pharmacotherapeutic and device-related options, and in future gene therapy that's really going to move the needle how long we can extend these patients. So is extension all great? Well, yes, but also no. So we do create a problem where we are seeing, we are imaging, and we are evaluating our patients less and less. And there is then a significant risk that there may be events that happen in between our monitoring intervals. There may be development of new disease in the fellow eye, which can be a significant problem. They're picked up late, since they usually will end up with poorer vision. And of course, we really want to figure out if is there a better way to reduce our treatment burden with truly individualized treatment. And home monitoring may be a means to address these issues and provide solutions. If we look traditionally, what did we used to, or maybe most of us still currently do for home monitoring of visual function? It is an Amsler chart. That is a patient self-actuated test where you're looking for symptomatic change in the patient's central visual function. There are a lot more devices that rely on maybe the same principle, patients doing self-doing a functional test, and of course, because these devices can then objectively try and measure the patient's performance, they can look out for changes in visual function at an earlier stage and in a more reliable basis. I think the device that has been the most successful or reliable with this is the 4C home monitoring device that has been around for perhaps almost a decade. And this device relies on preferential hyperacuity, perimetry testing to identify metamorphopsia. And this is an example of what it measures. It measures performance, and it needs to look at performance over time and against a baseline to detect a change in function. In their randomized clinical trial, which had almost 1,000 or more than 1,500 patients, it was actually abandoned early because at a pre-specified interim analysis, they found 82 patients had progressed to CNV, and there was a significantly smaller decline in visual acuity from baseline to CNV detection in the intervention arm compared to the standard of care arm, and that's why they felt it was no longer ethical to continue. A larger real-world data analysis showed that the home monitoring system helped to detect wet AMD conversions at better than 20/40 or better in 81% of patients compared with 30+% in standard of care alone. So this is effective at detecting disease earlier and preventing visual loss. So the question is, do I need a special device to do it? Many other companies have tried to do this on your mobile phone. In theory, a nice concept. In execution, maybe not always that effective. All Eye is one of the apps that have tried to do this. This relies on vernier hyperacuity. We did a pilot program during COVID where we got 2,000 patients to offer this app to use with a 32% sign-up rate with various diagnoses. And again, it would trigger an consistent abnormal results, would trigger a notification to the clinic, and the clinic can call the patients back. When we looked at the triggers that occurred, there were significant positive triggers that allowed us to pick up 7 patients with events before they were inclined to come back to the clinic. But if you notice, the positive predictive value was actually not great. It's pretty poor, less than 25%. And because of the design of the study, we couldn't assess accurately the sensitivity. There are other options. There is the My Vision Track app, which showed, again, very encouraging data in the feasibility study. Again, the major problem here is the specificity and sensitivity is a little bit less than ideal. There was a larger randomized control trial that tried to evaluate how these apps actually perform, and that was done in the UK, the Monarch study. They looked at 2 apps and a non-app-based kind of self-monitoring program. And what they did find was that the AUCs were in general very, very poor for detection of disease, were all less than 0.6. Only one test had a score that was associated with lesion activity, and their conclusion was poor diagnostic accuracy. And you can look at these AUC curves, they're more or less running down the middle. So these tests have limitations when you try to apply them in a real-world fashion. And beyond being an accuracy, there are issues with compliance in the real world. This data was from a group of clinics in the US, which tried to evaluate how effective the 4C system was in their program, and they found that a meaningful proportion of eyes never used the device at all, and all could not establish a baseline. And overall, the frequency of use was low, and continuous use of the device decreased over time. And that again is seen in the long-term results from the ALOF group, which found that over time, the frequency of use, as you can see up here on the right, decreased with time. But their data was encouraging in that they still found that 52% of the conversions could be detected with the system alert before the patients were symptomatic, and that's an advantage for them. And they did find that when they looked at the long-term visual acuity of the patients in this program, they maintained an excellent VA in spite of conversion. But again, these patients would be a self-selected group that are more likely to come back for early treatment and intervention if they had symptoms. The next area that's really potentially may change the way we manage our patients is home OCT. It really does have the potential to give you a truly personalized treatment interval. You're not waiting for your monthly, 6-weekly, 8-weekly, 12-weekly visit. You're actually getting them to do it at home all the time. And has been shown that patients can do this reliably, 80 to 90% successfully at home. So could it really change the way we individualize care and detect disease? But there are challenges. Firstly, you need to have image quality that's sufficient in a low-cost device. You need to have an analysis infrastructure. Imagine if your patient takes 2 OCTs a day, 365 days a year. That's for you 700 over OCTs to review, and that's for one patient. Imagine if you took care of a pool of 10,000 patients, you would not be able to cope. So manual interpretation is very laborious and must be addressed with artificial intelligence. And you have the usual things, coverage, reimbursement issues, and usability issues. The most mature device is the Notel device. In their pivotal trial, they looked at patients with a mean age of 77 years, and they found that 97%, again, clinical trial cohorts are very selective for the smartest, most compliant patients, but 97% could obtain successful scans. And in this study, they did the 5,400 scans altogether, and they found that in terms of looking at the endpoints, there was a good agreement in terms of detecting disease with a positive and negative predictive agreement of more than 0.8. And the visualization component also showed that the most patients were able to set it up at home. They performed an average of almost 6 scans per week, and the scan time averaged about 48 seconds. So 6 minutes of their lives, a very small proportion. They also evaluated their AI system for interpreting these OCTs because you can't do this manually. And they did find that, surprisingly, the home OCT had less variation because they're probably being done at a more frequent interval. And comparison of the 2 images and the grading processes showed a very high level of agreement. And they are not the only company on the market. This is data from a company that has been acquired by Heidelberg that looked at another home-based OCT, and they showed a good level of sensitivity and specificity for various clinical features and disease activation features. And we know other companies such as Zeiss have them in development as well. I think the biggest potential is really if you have a large amount of data, you may have the potential to improve the personalization of AMD management. And we always base our prediction algorithms based on 1 or 2 OCT scans. If you had serial OCT scans on a daily basis over time, it would really exponentially improve the amount of data you have, and that might enable us to pick up better markers for predicting all of the above: response, treatment interval, and so on and so forth. But there are still many barriers. Again, you need patient selection. Compliance is a problem. AMD patients are not spring chickens, unfortunately. They tend to be elderly, have multiple morbidities, poor performance status, and often may have limited technological expertise and experience. In a lot of real-world studies, as I mentioned, compliance is still poor. It can range from 25% and above, and we still haven't addressed the cost and logistics and issues with patient safety if you end up with a very high false negative rate, which is almost 50% for neovascularization with some of these app-based hyperacuity tests. So in conclusion, I think home monitoring holds a lot of potential. These hyperacuity-based tests have limitations because they're dependent on patient performance and may perform worse in real-world studies. Home OCT looks really promising because it's been effective in clinical trials, but the logistics, cost, and compliance issues will still need to be addressed. And I think we look forward for further development in this field. Thank you.
Thank you, Gavin. Thank you. Well, is there any question? If no, I have a question for you, Gavin. Well, a quick question. I think the images from home OCT device, they're kind of different from the conventional OCT images. So if you want to do AI for that, you need a kind of data set for the home OCT only. So it's going to be quite difficult. What do you think?
I completely agree. I have seen the quality of the Notal scans. Again, they're much poorer than a Heidelberg scan. Same with the potential Zeiss device. I think this company that Heidelberg acquired, the scans are a bit more similar to what we normally experience. But again, I think whoever is going to set this up is going to need to do big clinical trials to get enough data for it to be effective. So that's going to be the limitation.